is from the Kenyatta National Hospital Pediatric Department. Our topic for today is acute kidney injury in pediatrics. And our presenter for the day is Dr. Syriac Barubuche, and I'll be your moderator, Dr. Kailemia. Dr. Syriac is joining us in the next 5 minutes, just having a few technical issues. As we continue with the presentation, please feel free to write down your questions in the chat box, and we shall answer them at the end of the presentation.
They can open for me now the presentation so I can share the slide.
Okay.
Yeah. Hello? Sorry. Yes. I'm in presentations, tapatikana. No. Good afternoon for everyone.
Yes, good afternoon, Doc. You can proceed.
Good afternoon for everyone.
Good afternoon, Syriac. You can go ahead.
Yeah, I can go ahead. Thank you, Dr. So today the topic is pediatric acute kidney injury. So I'm Dr. Syriac Barubuche. I'm a pediatrician, nephrologist, working in Kenyatta National Hospital. So what we are looking today is just introductions, definition, etiology, classification, approach for the diagnosis and the treatment of the acute kidney injuries. Acute kidney injury is one of the most common consultation for nephrologists, especially inpatient, and it is a major risk factor for mortality and morbidity in inpatient care. It increases the burden for other diseases, hospital durations, and cost of the treatment. The mortality associated with the AKI is between 10 and 60%. That's the average. And sometimes it can go more than 90% when you have a multiple organ dysfunctions. In terms of the definitions, acute kidney injury is rapidly decrease in the glomerular filtration rate. So that's how much of the blood which can pass through the kidneys and which is filtrated, remove the toxin, then eliminate through the urine. So as now the glomerular filtration rate is decreased, you have now those accumulation of the creatinine and the blood urea nitrogen and the other toxin in the bodies. So, or either we have also inability to maintain fluid balance, acid balance, and electrolyte balance, as now the complication of the acute kidney injuries. So there are so many classifications you can use for definition of the acute kidney injuries, but the most common used in the pediatric is pediatric LIFO criteria. So where you have now the glomerular filtration decreased and also the urinary output reductions. So for the risk, we have a GFR decrease more than 25% as the normal GFR, and the reduction of the urine output at 0.5 ml per kilo per hour, at least for 8 hours. In the injury, glomerular filtration rate decreased more than 50%, and the urine output less than 0.5 ml per kilo per hour for 16 hours. And the failure, where we have most of our patients received in Kenyatta, is when you have decrease of glomerular filtration rate more than 75% as then compared to the normal, then or either decrease the glomerular filtration rate less than 35 ml per minute over 173 meters squares, and the urine output less than 0.3 ml per kilo per hour over 24 hours, or the anuria for 12 hours. Loss is when you have now persistent kidney injury more than 4 weeks, and the end stage renal disease is when you have now persistence of the renal injury more than 3 months. So this is now other classification called the KDIGO, kidney disease improved global outcomes and acute kidney injury network criteria. So those criteria are used basically in patient admitted in the ICU, where you monitor now the USC's urine output daily. So this one is not applicable in our setting because once the patient is coming, already patient has acute kidney injuries. Only the patient you can use this formula or this definition are the patient admitted in the ward. We are admitted that normal kidney function test. Maybe you give some drug like aminoglycoside, cyclophosphamide, etoposide, or other non-steroidal anti-inflammatory drugs. Then they have acute kidney injury. Then you can measure your creatinine level, and then you compare for the admission or normal. So still stage 1 is when you have now a creatinine increase our 1.5 to 1.9 term for the baseline, and urine output less than 0.5 ml per kilo per hour between 6 and 12 hours. So, or either you have the rest of the creatinine at 0.3 milligram per deciliter. So in our millimole per liter, what we have been using in our lab, that will be above 26.5 micromole per liter. Stage 2, the creatinine is increased now at 2 to 2.9 term for baseline, and urine output less than 0.5 ml per kilo per hour for 12 hours. Then stage 3, so this is now increasing with the 3 times as a normal baseline with the creatinine levels. Then urine output less than 0.3 ml per kilo per hour over 24 hours, or anuria over 12 hours, or either in children above 18, you may have either increase of the creatinine above 4 milligram per deciliter, which is now 88 times the 4, that will be almost 272 micromole per liter, or either decrease of GFR less than 35 mL, or either patient who is under hemo or peritoneal dialysis. So why today now we are revising and repeating acute kidney injury in pediatrics? So the previous acute kidney injury is between 1 and 5 in all children admitted in hospital. And by some study, they showed now 40 children who undergo cardiac surgery develop acute kidney injury with different stages. 20% of neonates below above 8 develop acute kidney injury, and 25% of the children who received the aminoglycoside will develop acute kidney injuries. And we remember gentamicin is our first line for antibiotic. Then 20% in critical care unit, and the rate might increase between 60 and 80% in the children who are receiving mechanical ventilation and the one vasoactive medications. And the better of this, more than 60% of the prerenal are the prerenal causes and can be preventable by IV fluid and by adequate hydration in the feeding. So how is now classification of the acute kidney injuries? So we have 3 classifications. The first classification according to urine output. You may have Uriguric renal failure, when the patient has less than 0.5 to less than 1 mils per kilo per hour. 1 mils per kilo per hour is for the neonate, not the children above 1 month. And most of the time, the cause is due to hypoxic ischemic injuries, especially acute tubular necrosis, or when you have, for example, cortical necrosis, because you have the kidney cannot concentrate the urine. That's why you still have the urine out despite having acute kidney injuries. So non-uruguric renal failure is you have now urine output. You have a urine output that's above 1 to 2 mils per kilos, and usually caused by the nephrotoxic insult. So by the study done for in any Western country, they found 30 to 50% of the neonate has renal failure are non-uruguric and they have a better prognosis. So another classification is according to the anatomies, which is the most commonly used in the pediatric and in hospital. So anatomy of the kidneys, we have now pre-renal causes, and most of them are caused by fluid losses, diarrhea, vomiting, inadequate secretion, for example, now the chronic liver failure, CCF. You can have also intrinsic, you have now the disease like acute tubular necrosis, acute intestinal nephritis, so nephrotoxic drug, radio contrast nephropathy, and you can also have the post-renal causes where you have, for example, the tumors or block the urinary catheter. So, as I said above, the pre-renal causes, most of them are decreased through intravascular volumes, where you have most of the common gastrointestinal disease, where you have now diarrhea and vomiting, where the children lose the fluid. Renal losses usually secondary to the diuretic. Blood losses secondary to the either some disease like thrombocytopenia, severe thrombocytopenia, DIC, or maybe after road traffic accident, which is most common, or increased sensible water loss when you have hypothermia, fever, and the burns. So, or either you have decreased effective circulatory volumes. So usually you can have capillary leaks where you have sepsis, then hemorrhagic fever, congestive heart failure, nephrotic syndrome, liver failure, vascular lesion, for example, in artery thrombosis, and the vein thrombosis. So in this particular, the blood volume remain in circulations, but there is no adequate circulation because there is now the effective circulation is not working. So another classification, which is not there, as I told you, I have a problem for my computer, is where the patient got now acute kidney injuries. So you have nosocomial, which is the most common in hospital-acquired, and you have hospital-acquired acute kidney injuries. Nosocomial is usually secondary to the antibiotic, and either non-steroidal anti-inflammatory drugs or chemotherapy. In the community-acquired AKI, you can have herbal intoxication, snake bite, bee stings, and all those causes you can cause acute kidney injury in children. How we make now our diagnosis for children with acute kidney injuries? So number one will be now how we take a medical history. The mother will just come telling you the child is not passing adequate urine. So one day without urine output, maybe the children and the parent will just come and tell you about the complication of the acute kidney injuries. For example, irritability, inconsolable crying, when the child has now the uremic encephalopathy. So some children will come, for example, having some skin rashes. So other will have, for example, obvious trauma. So you're supposed to take a good history to know underlying condition of the AKI in children. Then we do our physical examination, starting on our vitals, how the heart rate, respiratory rate, the temperature, the blood pressure, how our random blood sugars, how urine output. So those are vitals. So then you do systematic examination to know what is the problems. You found maybe the child has severe dehydrations. You found maybe the children some children have fluid overload. It depends, the severity also depends on the underlying conditions. So then later you do your laboratory examination. For laboratory, we do investigation to confirm now acute kidney injury, that is urea electrolyte, to know how now the child, how the severity of the acute kidney injury. Then you calculate the GFR, estimate the GFR. However, other investigations are be done to know either underlying conditions or either to know the complication. full hemogram, once you do hematology, for example, full hemogram to detect if there is maybe infections, thrombocytopenia, anemia, a sign of the cell cytosis, neutrophilia. Biochemistry, you check the, for example, liver function test to know if there is no acute kidney injury associated with the liver failure, it's called the Patorino syndromes. You need to check a urine analysis. Urine analysis sometimes is difficult because most of the patient, they become anuria. So this urine analysis is done for the patient who got AKI in the hospital setting and for the non-oliguric AKI. So you can do microbiology, you can do serology and immunology. It depends on how the presentation, like example, if you suspect the lupus, you can do antinuclear antibody, double-stranded DNA, you can do ANCA, complement 3, complement 4, and you suspect vasculititis. You can do KUB ultrasound to know if there's no obstruction of the urinary flow, or if there's no abdominal masses, renal biopsy to know underlying conditions. And sometimes you can do fluid challenge. Fluid challenge, you give a patient 20 mils per kilo of body weight, then you give analysis between 1 to 5 milligrams per kilo, you observe. If there's no urine output even in 2 hours, it's most likely the patient has now the intrinsic acute kidney injury, and the patient may require dialysis. Sometimes we may need to do renal biopsy to know the underlying condition, especially when you have AKI associated with the high blood pressure, proteinuria, hematuria, and the edema, what called the rapidly progressive glomerulonephritis. Or some conditions, like for example, AKI associated with the HIV, hepatitis B, or AKI associated with Gutt's-Patcher syndrome. So those diseases you need to do the biopsy. A lot of biomarkers, INGAR, interleukin 18, those kidney injury molecule 1 are used elsewhere, but not our setting. So in our setting, we are not using them because they are costly and not available. When you say so now the urine in this, in the preliminary, in the intrinsic, as I said, so usually is just to know the specific gravity and the urine concentrating ability of the kidneys, and you check now fresh expression of sodium. So in the preliminary, you have those values, and the intrinsic, you have those value. But as I said, this one is not applicable. Most of the patients who come in acute kidney injury, because most of them, they are anuric. So this one you can't use from the diagnosis. So now we are going to see how we can do management of a child with acute kidney injuries. We'll see how step we can use to treat a child with acute kidney injury, and sometimes how we can prevent severe acute kidney injuries. So one of the goals of treatment for underlying disease, then you treatment of the complication and you prevent further progressions, that's supportive care. And another mode of the treatment, just replacement therapy. So now let's look now about, for example, how we can treat now underlying conditions. So one, if the child comes, for example, diarrhea and vomiting, what we need in that scenario is just to give the adequate fluid. So making sure the child is get adequate fluid to restore circulations. If the child need albumin, you give albumin, but you don't give albumin without restoring the blood circulation. So how we give now the bolus, normal saline or ringer's lactate. You can give it between 10 and 20 ml per kilos, then you observe. So you can repeat the one boluses. Some children may need, for example, the blood according to the condition. If you have, for example, a child with hemolytic uremic syndrome who has anemia and thrombocytopenia, AKI, you may need to transfuse as soon as possible. So some children may require glucocorticoid or immunosuppressive treatment. That's the case of the either rapidly progressive glomerulonephritis, ANCA-associated vasculitis. Those one we need those medication, and basically they are done by the nephrologist. So once you suspect now this condition, it's better to refer to nephrologist as soon as possible. If you suspect now the urinary tract obstructions, you may now do either surgery to remove obstructions, and if it is the catheter, Foley catheter obstructed, you just remove and insert another one. Even yesterday, I saw a child who has AKI secondary to the obstructed urinary catheter. So it's more common in hospital setting. So now how the renal specific therapy will just focus for the underlying conditions. If the patient has now high urea and high uric acid, you will give now, if the child has high uric acid, you can give allopurinol. Rasburicase is good with drugs, but it's very expensive and is not available in our setting. So if now the patient has, for example, some complement like pigmentoria, uric acid, methotrexate, toxicity, you can give also you force the uresis and alkalinizing for the urine. So you give a lot of fluid, then you give Lasix. If you suspect, for example, now paracetamol toxicities, you give N-acetyl cysteine and you recommend the dialysis as soon as possible. If you have heavy metal toxicity, you give dimercaprol. And if you have ethylene glycol poisoning, you give the ethanol. Those are the drugs you can give always. And in the case you have patient with acute kidney injury who require any radiocontrast nephropathy drugs, so you need to hydrate the patient before radiations, and you need to hydrate again after imaging. So now we come for supportive therapy. So supportive therapy will come again also for the fluid management, because some patients they will become either severely dehydrated or either they become with fluid overload. So after assessment, your fluid status is better if you can have the chart for the weight daily to know if the patient is accumulating fluid. You support to have now the urinary catheter to monitor your input and the output. Also, you remember to monitor your blood pressure in the other clinical examinations, because the blood pressure will tell you if the patient is increasing fluid retention as long as the blood pressure is increasing and the patient is not passing urine. So it's now for the clinician to make now sure how the status of the child. Is it hypovolemic shock? Is it hypovolemia, severe dehydration? Does the child has normal volemic status, or does the child is fluid overload? So you monitor now daily weight, and you support to calculate accurate input in the output. So as I said, you support to have the urinary catheters and monitor your vital sign and the renal status. If the patient has now the volume depletions, where you have the patient who has dehydration in the shock, so you use now the fluid. How you calculate your fluid? So you give now you correct now your shock or your dehydrations, then you calculate your maintenance fluid. So usually sometimes for the first day is a challenge, because patient may come and they don't have any specific sign to tell you how severe dehydrated, because some parents they don't remember the weight of the children. But by your clinical assessment, some children you can know maybe sunken fontanella, so in a bit past urine more than 1 day or 2 days, you may find now dryness of the mouth mucosa. So those one you can suspect how the child is dehydrated. So you get now the capillary refill time, skin tagger, the blood pressure. So those one you can tell how severe the child is hydrated. So how you calculate now your maintenance fluid, you get now insensible water losses. So which is between 300 and 400 ml per meter square per day, plus urine output, plus ongoing fluid losses. So in that one, you calculate now the loss by the loss, whatever it is now, nasogastric suctioning tube or the urine or the stool. So any vomiting is considered as 10 ml per kilos. Any diarrhea is considered 10 ml per kilo per loss, and the normal stool at 5 ml per kilo per day. So if the child increases the temperature above 37.8, any increase with the temperature, you will increase 5 ml per kilo as insensible water loss. So for the neonate, insensible water loss is calculated between 20 and 30 ml per kilo. So then the children above 1 year calculate using 10 to 15 ml per kilo to calculate insensible water losses. So if the patient has fluid overload, you will correct only the loss. You don't give nowadays a lot of fluid. So maybe one condition can tell you how severe the dehydrations, even if it is not 100%, through is the sodium levels. All the patient who have hyponatremia, most of them, they are severely dehydrated. So sodium level, the blood pressure, capillary fill time, sunken eyes, those one can tell you how severe dehydration you have. So also the supportive therapy, sorry for this one, which is not we are unable to see it. We are now looking about now the electrolyte. Usually we can have now either potassium is the most common electrolyte imbalance. We have hyperkalemia, we have hypocalcemia, and we have most of the time hyponatremia in case of the severe dehydrations. And in the case of fluid overload, we have hyponatremias. Sorry for this one, is disturbing me kidogo. So if you have now the hyperkalemia, so when the potassium level is supposed to be above 6 millimoles for this slide. So those we says the peak the T wave is only for the patient who have admitted in the ICU, they are under monitoring. So usually our patient is no monitor. Usually use your potassium level you get from urinary UCs or the one you get from blood gas analysis. If the patient now have hyperkalemia, so what you're supposed to do, one is remove potassium from IV solutions and maintain the patient on low potassium or potassium-free diet. So the food which has potassium, maybe for the big children, those all the vegetables and the fruit, they are rich in potassium. For example, the sweet potatoes, orange, bananas, they are really higher in potassium. So you're supposed to avoid in that cases. So then you can also bind hyperkalemia. You have so many drugs you can use. So usually you can use calcium gluconate to stabilize the myocardium. The dose might be variable between 0.5 to 1 mils. 0.5 mils for the unit, 1 mils per kilo for the children above 1 mass. So they do support to run between 10 to 15 minutes. So if the patient, the blood gas analysis is not showing respiratory acidosis, you will give now the sodium bicarbonate. The dose is 1 mils per kilo to run between 10 to 15 minutes for the unit and 2 mils per kilo for the children above 1 mils. So you need also to shift your potassium from extracellular to intracellular. That's why you use now your insulin and the glucose. Insulin is 0.1 mils per kilo. So the glucose, you will choose which concentration according to the weight of the child. If the child has, for example, 40 kilos, you cannot use 5% or 10%, apart if 50% is not available. If you have 50% available, it's better to use 50% because it's supposed to give that solution is within 30 minutes. So 50% use 1 mils per kilos. If you use now 10%, it will be 5 mils per kilos. If you use now 5%, it will be now 10 mils per kilos, plus insulin 0.1 international unit per kilo to run over 30 minutes. So then you can nebulize with salbutamol as you support to repeat your UCs or blood gas analysis within 2 hours to know your response on the treatment. So some children will have also the hyponatremia. Hyponatremia, usually it's a sign of the fluid overload, and most of the time in the case of the AKR, and it's due to extracellular fluid dilation of the overload and not sodium deficit. So if patient has severe symptomatic sign of the hyponatremia, this patient who is having vomiting, convulsions, irritabilities, so we may need to give an hypertonic saline, 3% at 0.5 millimoles per mil. So that's 0.5 mils per kilo. That can create until now the conversion stop. Aim is just to have at least sodium level at 125. So you may repeat the same concentrations in the same amount, 0.5 mils per kilo, and the maximum dose can be at 5 mils per kilo. So the lower dose is 0.5, the higher dose 5 mils per kilos, but most of the time it's better to use between 3 and 5 mils per kilo. Then you observe the response on the treatment. So the formula used now is when the patient has now a persistence hyponatremia. So the normal sodium is 140 minus current, or the calculated the sodium concentration times 0.6. This one is average of the concentration of the water in the body times the body weight. So what you will get nowadays, how many millimoles or how many milliequivalent of the sodium you're supposed to give for the patient. So the correction usually it's better to correct slowly. For even 24 hours, you correct between 8 and 12 milliequivalent, and within 48 hours, you correct between 16 and 18 milliequivalent. Don't over corrections for the sodium, because we have now sodium shifting, water shifting, and in that scenario, we have nowadays the brain shrinkage and the brain edema. In the presence of anuria, or if you have hyponatremia persist, you may require to do dialysis. For the patient who have hypocalcemia, so acute hypocalcemia, you can give 0.3 mils per kilo of 10% calcium gluconate between 10 and 30 minutes. And you remember to create also the magnesium at 0.2 mils per kilo of magnesium sulfate, 50%. So, and you may need now to do maintenance of the magnesium sulfate at 1 mils per kilo per day. So always, as I advise, if you have a patient who has acute kidney injury, have hypocalcemia and has hypokalemia, it's advisable to create calcium first, because once you give your sodium bicarbonate, the calcium will be very, very low. So you give a calcium gluconate, then you give sodium bicarbonate after. So for specific therapy, you may need now to create acidosis. Acidosis is one of the complications of the acute kidney injury and has been associated with the poor outcome. So a severe metabolic acidosis it's a worse complication of the acute kidney injuries, because it's causing now a lot of complications, including the accumulation of the lactic acidosis in the body because of beta oxidations. It increasing anoxia and ischemia. It increasing now and it deteriorate the lymphocyte and neutrophil responses, so which worsening your infections. Also, it reduces the response of the insulin, which cause now most of the time hyperglycemia, or another complication you may have is now poor response on the inotropic support. So if the patient has severe metabolic acidosis with pH less than 7.1, bicarbonate less than 12, it's better to give sodium bicarbonate cautionary to monitor now the response on the treatment. So always you make sure patient who have pure metabolic acidosis, you give sodium bicarbonate. So there are so many different formula you can use. So the most common one is you can give base excess times 0.3 times the weight of the patient. You can give half of that fluid within 30 minutes, and the half of it, another half of it between 4 hours and 12 hours. So always remember to repeat your blood gas analysis after 2 hours to know the response on your treatment. So other supportive therapy, you remember always to adjust your drugs, especially the nephrotoxic drugs, according to the estimation glomerular filtration rate. So you monitor the drug levels where it is possible and is indicated, especially for example, vancomycin, aminoglycoside, some chemotherapy, because you may have a patient who needs those drugs and they don't have another choice apart to give those drugs. So for example, a child who has a cancer, who needs the chemotherapies. So you will give that drug the lower dose, then you monitor the levels. So if possible, you avoid the nephrotoxic drugs. So you monitor your blood pressure, aims to have at least normal blood pressure, avoid now blood pressure fluctuation, hypertension and hypotension, try to avoid. Keep blood pressure between at least between 70-90 percentiles. Avoid the fluid overload, which will contribute to the hypertension, and avoid now the salt intake, especially for the big children. So some patients may require now the fluid restrictions, another one will require the diuretic and higher dosage. It depends how the child look like. You remember always to initiate area feeding, and if the child cannot tolerate oral feeding, you give now the either nasogastric feeding, or either you can give now the total parental nutrition. So you prevent and treat any infections. That is meaning now, remember our hand hygienes, or you do any procedure in sterile manners. You maintain adequate nutrition, because acute kidney injury is a high catabolic state. It requires high calories, especially with the neonate, where you're supposed to have at least input in between 110 and 130 kilocalories per kilo per day. So you're supposed to feed adequately. The high biological value proteins, lower phosphate and potassium diet must meet now the recommended calorie requirement. That's why you need now to cooperate with a nutritionist to advise for the quality and the quantity in terms of the food you need to give your patient. And so you're supposed to explain to the parent, we are restrict this kind of the food because of the condition. So you always discuss with the parent, discuss with the children, if the child is able to understand what is going on. The parental nutrition may be required sometimes if enteral feeding is not possible, and the infant should receive, as I said, at least minimum 120 kilocalories per kilo per day. Older children will receive now appropriate maintenance calorie according to the age. That's why you need to call now at least the nutritionist to assess, because no one can know everything. So sometimes our patient can respond well, and the other one cannot respond well on medical management. So those one who are not responding may require now indication for dialysis, what called the renal replacement therapies. So there are so many indications for dialysis, but let's we talk about the few of them. So one is now fluid overload in the presence of the oligoanuria. If the patient has fluid overload, the way you calculate the fluid overload, we calculate now fluid in and the fluid out. Then you calculate, you divide by admission weight times 100. So let's assume you have a child of 10 kilos. The child who admitted 10 kilos, you give, for example, 1 liter, which is 1,000 ml as now normal maintenance fluid. Then you found the following day, the child has 0 urine output. It's meaning your fluid in, the fluid out, it's 1 liter. So then you divide by the weight of the child, which is now 1 divided by 10 times 100. You find now within 1 that days, the child increased 10% of the normal weight. So that's the emergency fluid overload. So you're supposed to have now a chart, a daily chart, where working together with the nutritionist, you measure the weight of the child, you measure the blood pressure, and you have the child to know how much I'm getting in, how much I'm removing in, to know how fluid you're supposed to restrict for the patient. If you have now severe electrolyte derangement, hyperkalemia, which not respond on medical management, when you have symptomatic hyponatremia, retractable hypocalcemia or hypophosphatemia, those are also another indication for renal replacement therapies. Severe metabolic acidosis, pH, which is less than 7.2, you are given sodium bicarbonate, you are given your adequate fluid, you give your blood transfusions for the children who require blood, and you found the child how his blood gas analysis shows severe metabolic acidosis, pH less than 7.2, bicarbonate less than 12. That's the indication for dialysis. So some children will come with symptomatic uremia. So it can present in a different way. The most common is uremic encephalopathy, where the child will come with seizures, retracted neck, which can confuse us now the neonatal tetanus. So you can have now irritabilities, lethargies. In uremia, in GIT will manifest now as coffee ground aspirate or hematemesis. Uremia in hematological system will represent now as elevated the INR most of the time with thrombocytopenia, and in the bone marrow, it can cause now the bone marrow separations. So, and also in the skin, you can have now easy bleeding as the result of the uremia. So in other indications for dialysis is when you have now intoxications with salicylate, ethylene glycol, methanol, isopropanol, metformin, valproic acid, lithium, any poisoning you confirm, you need to do dialysis to remove the toxins. So other indications, when you need, for example, to support nutrition. That one usually is used in a patient admitted in the ICU because you may need to give so many fluid. You need to give for maintenance fluid, total parental nutrition. You need to give the blood. You need to give a catecholamine. For example, now you give dopamine. You may need to give another drugs. So you need to give so many drugs for that patient. Now you need to create the spaces so that you remove some fluid, then you get where you can also feed the patient. So that's another indication. So sometimes you can also do actually you can do dialysis for the children who has, for example, snake bite, bee stings. Those also are other indications. Another indication you can do is for the patient who have urea above 30 and is not passing urine adequately. That one is indications. And indication of the anuria more than 24 hours is also required for dialysis. So for the dialysis, we have now several modalities. When we prefer the modality for dialysis, you consider several aspects. One is you need to save the life. That's the most important when you do dialysis. So, earlier dialysis may improve the outcome and it may save the life of the child. In some conditions, it gives the good outcome. So when you have, for example, now the condition like sepsis, burns, and the crash injuries, where you have microglobinuria, hemoglobinuria, let's you have a child who has acute kidney injury with, for example, sickle cell disease, with road traffic accident, a child with burns, that's emergency dialysis because those children, any delay, it associated with the poor outcome in terms of the mortalities, in terms of the duration of the treatment, or either in the complication of the chronic renal disease. So in those scenarios, dialysis may be considered even if the renal failure is not severe. So with minimal drainage of the kidney functions, you can just do dialysis to save the life of that infant or that child because it gives you the better outcomes. So you can do dialysis when there's need to remove the fluid, when you need to give the blood product, and when you need to do nutritional support, as I said. So sometimes also you consider now economic parameter of the parent. If you have a child who have, for example, 8 years, are you rushing for peritoneal dialysis or you do hemodialysis? So you look how the parent, if they have insurance, if they are able to sustain now hemodialysis after discharge, what is the condition you can use. So you look also, you discuss with the parent each modalities, and also you discuss with your staff. So if your staff are competent for hemodialysis, you can't forcing them to do peritoneal dialysis because they will fail. So also you look at the competence with your staff and what is now the common in your setting. So in small children, usually use peritoneal dialysis. In the big children, we can use both peritoneal and hemodialysis. Always you check also the blood pressure. If the patient has lower blood pressure, hemodialysis is risk. If the patient has high blood pressure and has fluid overload, and the condition can allow to do hemodialysis, will be the best choice. If the patient has, for example, persistent hypothermia or hyperthermia, and has lower blood pressure and has bleeding tenderness, the peritoneal dialysis will be the first choice and will give better outcome. So the modality we have in our setting is just peritoneal dialysis, which is the most common used in children in our setting. For example, from the last 4 years, I dialyzed in pediatric renal unit 900, more than 900 children. Those are not including the children admitted in main ICU and in the pediatric critical unit. In 2019, we dialyzed 194 children. In 2020, 1940 children. Last year, we dialyzed 345. And as per now, we have more than 170 children dialyzed, which is a heavy projection to dialyze more than 300 children in this year. So for hemodialysis, we still have some children, and usually we prefer for the children above 5 years who can have at least more than 15 kilos. But we have young child who have 3 years and 9 months under hemodialysis. So it can be done. So just try. We have the good setting, you have the power to do it, it can be done. So continuous renal replacement therapy is a good idea. It's costly, expensive. So we never use any children in our setting. Most of the time has been used for the adult populations. So the factor which we influence now your choice for the renal replacement therapy, one is the goal for the dialysis. If you need now fluid removal or solite clearance or toxin removal. So if you need to remove the fluid, your hemodialysis is working better than peritoneal dialysis. If you want to remove now the toxin and allow the patient to eat, your peritoneal dialysis will give you the better option than hemodialysis. Also, look at the clinical status of the child and the hemodynamic stability. That's what I said about now the blood pressure, bleeding, the tenderness. So if you have now lower blood pressure, it's better to use a peritoneal dialysis. If you have bleeding and tenderness, it's better to use now the peritoneal dialysis. Also, feasibility for peritoneal dialysis and hemodialysis, you look about the blood vessels. If now you can have hemodialysis catheter, which can allow you to insert now the catheter in the blood vessels, either jugular, femoral, or really in subclavian. So we try to avoid the subclavian because of the complication associated with that catheter. So also you look at the medical personnel and the institutional preferences. So if you need anticoagulations, so it's better to use now the peritoneal dialysis because the risk of bleeding is very high during the dialysis and also after hemodialysis. Also, sometimes because you look about it because of the treatment and the supply. That's why, for example, I was just saying, also you assess the economic status. If you suspect maybe the patient will need dialysis for a long time, so you look how the parent can afford. So you may choose peritoneal dialysis because it's done in hospital. Then once the patient, the parent, they have at least KNH, we can allow them to be discharged and come back for the hemodialysis. Now you can discuss how you can discharge and how you can now change peritoneal dialysis to hemodialysis, at least to allow the child to go home. Or sometimes also you can treat the parent to do peritoneal dialysis at home. You have one child now under peritoneal dialysis more than 4 months at home. It can be possible. It has been done. So my take-home message today, acute kidney injury is an independent factor of outcome. When you look about, for example, the mortality of the children with acute kidney injuries, it's between 1 and sometimes at 90% increase the risk of mortalities. So it's associated with the highest mortalities. And as I said today, each day we lose a child with acute kidney injury because of the delay in referrals. So some children, they die at the pediatric emergency unit, or either they die in the ward before dialysis. At least every day we have one child die because of acute kidney injuries. And those children, more than 99%, their mortality can be prevented by adequate fluid, earlier referrals, and by adequate of breastfeeding. Earlier diagnosis and referral is crucial in the management of the acute kidney injuries. So that one we can agree with the intensivists. Any child who has severe acute kidney injury, it doesn't matter how you have your ICU good team, because if the child has creatinine, for example, of 115, had urea of 80, has, for example, now the pH of 6.7, that pH alone it's enough to make the child die. So I'm always request now my friend, doctors, the nurses, earlier references, earlier referral for the children with acute kidney injury may save the life. If the parent, the child is not passing urine, don't say, let's breastfeed again. Do your UECs, and if found they are deranged, they find immediately where the facility where you know they can do dialysis if there is complications. If you are unable to do UECs, you can refer. UECs can be done at the Kenyatta National Hospital or any other facilities where they can do dialysis, but don't deal with the patient. So supportive therapy is always very important. You remember to adequate feeding, total parental nutrition, so your IV fluid, your blood transfusions, your other drugs. So always support your patient, give a counseling for the parent, that will at least to increase the moral support, that one will help. So earlier dialysis is always saving the life, and peritoneal dialysis is more the choice for replacement therapy in pediatric, especially in our setting. And you can do peritoneal dialysis even in your hospital, as long as you are able to fix now the peritoneal dialysis catheter. If you don't have peritoneal dialysis catheter, you can use big central line, or can use an nasogastric tube. So that one you can use as improvised peritoneal dialysis catheter, and the peritoneal dialysis fluid you can use ring as lactate and the glucose. There's some children with dialysis at Kisi, and the other one with dialysis at Nakuru and Naivasha, just where the doctors have been just calling, they consult online, we give them instruction, and they dialyze. Some of them, they have been improved and discharged at home. So thank you for your attentions. So it is now the time for comment, and now for the questions.
Thank you so much, Syriac, for such an informative presentation on pediatric acute kidney injury. There are some questions that are on the Q&A. I'll start with a question from Salome. She was kindly requesting if you could elaborate more on the fluid challenge.
Okay, thank you so much. So initially, the fluid challenge has been described now as to know if the patient will pass urine or not. And now it's a good indication for dialysis. So how you do patient, what you use for the fluid challenge is just to know if the patient usually has either pre-renal or intrinsic renal injuries. If the patient has pre-renal, once the patient comes, they give your bolus fluid at least 20 ml per kilos, at least after operation of the dehydration. Because if the child comes severely dehydrated and we give your bolus, you don't expect to pass urine. But if you give now your bolus 20 ml per kilo, and you give a Lasix at least 2 milligram to 5 milligram per kilo as a starting dose, you expect to get at least urine output within 2 hours. If there's no urine output, it tells you the patient may have severe acute kidney injury compromise. Either you have pre-renal and intrinsic together, or you have intrinsic together, and your patient will not need another Lasix to change the kidneys. So the patient may need earlier dialysis. That's how you use the fluid challenge.
Thank you for that. I think the second question you've answered it, but maybe you can elaborate more on the Lasix challenge in terms of dosage and protocol of how Lasix can be given in acute kidney injury.
So for the Lasix challenge, as I said, you try to see if the patient can make a urine. If the patient can make a urine after giving the bolus in the Lasix, you can give a higher dose or lower dose. Lower dose is just 1 to 2 milligrams per kilo. Higher dose is 5 to 7 milligrams per kilo. So you can give a higher dose or can give a lower dose. So now, in this particular acute kidney injury, you have two scenarios. One scenario is patient who come anuria and severe dehydrated. So that's one we give now for bolus, then we give Lasix at 2 to 5 milligrams per kilo. Then you observe if there is urine. If there's no urine, so the patient may require urgent dialysis. You prepare for dialysis as soon as possible. If the patient make a urine, this patient may have a prerenal AKI, and at least I can try to monitor with the IV fluid while I'm preparing maybe other medication or dialysis. Another scenario is the patient who will come with the fluid overload. For the patient to come with the fluid overload, edema, hypertension, so that one also you can give the fluid, the Lasix challenge. That one will not require to give a bolus. We give just Lasix, a higher dose between 2 and 5 milligrams per kilo per dose. Then you observe if the patient can make a urine. If the patient can make a urine, you can just use a higher dose of the Lasix to remove to try to remove the fluid overload. Then you prepare for dialysis. I think those are two modalities. They are different scenarios. So it depends how the presentations. That's where you can use the Lasix.
Thank you for that. I think that was very clear. There's a question from an anonymous attendee. If you could kindly give a practical example of how to estimate the GFR in children.
So the way you can estimate now GFR in the children, you may support to have now the normal GFR, because GFR for the children may be different from a premature baby, for the first week of life, after 1 month, after 1 year. So usually the children get the normal GFR at least at 1 year. So if you have now the range, the normal range for the GFR, now you calculate the GFR to know how far your glomerular filtration has been decreased. So also the lab support use now what we call the now Jaffe method, where they support use now the micromole per liter as your creatinine levels. How you calculate? You take the height of the chart, times the 40, which is the constant, then divide your creatinine in micromoles. So whatever you found now in terms of the creatinine levels, you will now compare with now the normal creatinine level at the same age, in this usually at the same age. So and if you want to estimate now how far you have your creatinine clearance divided, reductions, you check now your creatinine you have, then you divide by the normal creatinines. Let's I give an example. At least around one month, the child is supposed to have a normal creatinine around 25 to 35. Then the child came with the creatinine of 500. So if the child has 1 month, we estimate now the height at around maybe 52 centimeters or 54 at least 52 to 54 centimeters. So you get now 40 times 52 divided by 500. So what you will get, you will the hypocalcemia, when, for example, you say, let's give sodium bicarbonate without initiating with the calcium gluconate, your patient will have severe rebounding hypocalcemia. So we're supposed now to give fast calcium gluconate, because most of the lab are not measuring the bone biochemistry, and you don't get the result as soon as possible. And most of the times, the medical officers and other people, they forgot to test calcium when they have the patient the acute kidney injuries. So that's where we support to give now the calcium gluconate before you give your sodium bicarbonate. That's the number one. Number two, if you have lower calcium and lower magnesium, because in magnesium and the calcium, they are matched together, it's cofactors, I said. If the calcium is low and the magnesium is low, you can't improve your calcium level without correcting the magnesium. That's the role we give now the magnesium sulfate, then you give calcium gluconate or another calcium supplementation to improve your calcium levels. So no relationship between phosphate and hyperkalemia.
There's a question on effects of glucocorticoids in acute kidney injury.
So the glucocorticoids are not used in simple acute kidney injuries. So this is the drug we use only for it can be used for these two scenarios. One scenario is the patient who has refractory septic shock and has acute kidney injury, and it's used when you try the other drugs. You give inotropic support, your IV fluid, your albumin, or in other drugs, the patient is not responding. That's where they use a glucocorticoid and to try to increase now the vascular compartment. That's the one. Usually it's the drug given and prescribed by intensivist. So the second now option, which is most common in pediatric nephrology and the adult nephrology, are the patient who have acute kidney injury in a condition called rapidly progressive glomerulonephritis. Those are the conditions associated with vasculitides or Goodpasture syndromes, or whether the child has acute kidney injury and the lupus, systemic lupus. So in the clinical pictures, because not all of us were able to do biopsy before you found what's called the crescent kidney biopsy, the patient will present with hematuria, proteinuria, edema, acute kidney injury, and hypertension. So those patients will be beneficial to get now metaprednisolone at 10 milligrams to 30 milligrams per kilo per dose, but usually in pediatric we use the lower dose at 10 milligrams per kilo per dose, and the cyclophosphamide. That's why I use now the glucocorticoid.
The next question is from Evans. Please comment on the fluid allowance for nutrition versus IV fluids. I have had challenges where the given volume allowance for nutrition is too little to attain the caloric requirement for the child.
This is the hard question, but also a simple question to answer. So there's not any single formula you use for each child, because each patient, it comes as unique. So you will check now the food status of the patient. Some children may require to give adequate food. So adequate nutrition, maybe breast milk, maybe total parental nutrition, or maybe normal feed. It depends how the volume status. That's number one. So number two, also it will be depends now how the tolerability of that fluid, and how the tolerability of the total parental nutrition or nutritional, and how the nutritionist will comes to intervene. Remember, most of the patients are admitted in pediatric renal unit or casualty, where there's no nutritionist. That's why we found patient has been given 100% of the IV fluid, because there's no nutritionist to support. But for post-admission, when the nutritionist will comes, we assess now hydration status. If the child can tolerate now total intake as feed, we change fluid to normal feeding. If the patient is unable to attend, what you calculate now the calories. Normally, the nutritionist will come and calculate their calories according to the requirement. So now they say, Dr. Me, the one who have been working together, they say, whatever I can find in the tolerability for this child, I can give, for example, 80% as feed, maybe you give it 20% as the fluid. So the nutritionists themselves to calculate and they give us now how much we're supposed to give. But if the nutritionist is not there, so for us, we'll assess now the tolerabilities. We'll start with the fluid, then we give it the smaller amount of the feed. If the patient is tolerating the feed, you will increase by every feed. So I think now it's clear that he cannot understand the role of the nutritionist in me, acute kidney injuries, and I can invite him to come in the pediatric renal unit to give us even the session. Thank you.
Thank you for that. The next question is from Norbert. A common problem with PD is recurrent blockage by intestinal tissues or mentum. What is your experience in this? And is there a risk of introducing infection as you adjust to the tubes?
So usually some children may have a problem for outflow because some children will be admitted the higher INR. Some of them, they have INR even more than 10 because urea above 80, 90, it's associated with the higher INR. They have easy bleeding, the blockage. So what you use, if you are not familiar, it's better to call the senior nurses who has enough experience. We are not just moving the catheter. Usually we flush with the heparin. So in that now heparin can prevent the clot, or we add small heparin in maintenance in the peritoneal dialysis fluid, but you are not removing now the catheter again and again. So that's number one. Number two, if for example we are unable now to use the heparin, maybe you have someone who is not familiar, so all the procedure you do in sterile manner. So wash your hands. After washing your hand, take your sterile gloves. You have another persons, you clean the patient before touching him with iodine. After cleaning now the dressing, that's where you're supposed to touch the PD catheter or hemodialysis catheter. So as long as the patient has no other risk factors, so the risk to get infections by manipulating it's low, but however, you can now cause the injury of momentum, not the infection.
We'll finish off with this last question from Patrick. Good afternoon. Thank you for a timely and insightful presentation. Kindly shed light on how Lasix worsens acute kidney injury. And I think this you had mentioned, but you can repeat, and how to know if it is safe to give. Okay, so acute kidney injury can be associated by the drugs. And one of the most the drugs is the diuretic. So I give an example. You have admitted the patient who have nephrotic syndrome. That's the one example. So the patient has fluid overload, but also has lower albumin. So with lower albumin, most of the fluid are in interstitial, not in intravascular compartment. It will be a patient with the CCF, or either a patient of the renal of the liver failure. So now your target as a clinician is how you can remove now a lot of fluid. Once you use now Lasix, without now checking input and the output and measuring the weight of the patient, so you end up to cause now the acute kidney injury by excessive use of the Lasix or the other diuretic. Because you are removing a lot, but not replacing what you are removed. So it is just we cause acute kidney injury because the imbalance between input and the output. There's another question. Maybe you can just repeat on how to manage hyperkalemia, what to start with when you want to bind.
So when you manage now the potassium as high level as hyperkalemia, it will be better to start with the calcium gluconate, because once you have now higher potassium levels, because the impulse between sodium and the potassium and the membranes, the depolarizations in the nerves, the conductivities. So you need to stabilize first now the myocardium. So the best drug is just calcium gluconate, which stabilize now the heart. At the same times, also it prevents the lower calcium levels. So you will start with the calcium gluconate. The dose will be between now 0.5 to 1 ml per kilo, 0.5 ml per kilo for the neonate, and the 1 ml per kilo for the children above 1 month. So the second drug we use, if you are able to do blood gas analysis and your patient has a pH less than 7.2, bicarbonate less than 12, so you can give sodium bicarbonate. Don't fear about now the sodium levels, because sometimes a clinician will say that's sodium of 190, I can't give sodium bicarbonate. Remember, the sodium bicarbonate you are giving is a smaller amount and they can equate as doses than to lift it itself. So give now sodium bicarbonate 1 ml per kilo for the neonate and 2 ml per kilo for children above 1 month. So the duration is between 10 and 15 minutes. Then another drug we use now is shifting now the potassium. You use the soluble insulin, the one used most of the times. The dose is 0.1 international unit per kilo, and you mix with now the glucose. You can either mix with the glucose, or you can either give it one of either IV, or it's better to give both IV. Maybe you can start with the insulin, then you give glucose immediately. However, it's better to mix to avoid now the episode of the hypoglycemia. As I said, if the child have a lot of weight, it's better to use the highest concentration of the glucose, because you can able to monitor and to give now that solution within 30 minutes. So better now 50%, we give now 1 ml per kilos. And if you use now 10%, use 5 ml per kilo. And if you are using now 10, if you're using now 5%, you use 10 ml per kilos. So it's you to choose according to what you have in the hospital facilities and what we learn with the timeline of 30 minutes according to the weight of the patient. Then later alone you can do nebulizations. You repeat your EECs within 2 hours, or blood gas analysis within 2 hours. If potassium remains still high, you can do second binding potassium and shifting potassium while you are waiting your pediatric surgeon or another surgeon to visit the catheter, then to initiate now the dialysis.
Thank you for that. I think we will close here for today. Yeah, I just want to say thank you again, Dr. Syriac, for a very informative presentation on pediatric acute kidney injury. And from the take-home messages today is that supportive management is very important, and for early diagnosis and treatment, and that peritoneal dialysis is the modality of choice for renal replacement in children. I'll just leave it to Syriac. If you have anything else to add, you can add now, and then we'll close the meeting.
Yeah, thank you, Dr. Kairemia, to preparing now this acute kidney injury. The reason we are just talking about acute kidney injury, it's because it's preventable and it is associated with the highest mortalities. Now imagine when you are losing each day a child because of acute kidney injury, it gives you frustrations, and those mortality can be prevented at 100%. So take home message, it's just always check the upper of the child, ask the mother how frequent of the urine output. So if you can assess now the breastfeeding, because more than 50% of the children we are admitting in Kenyatta National Hospital, if AKI, they don't have any other disease. It's just inadequate breastfeeding, poor breast milk. So if the mother has no milk, it doesn't harm to give either IV fluid or either formula milk, as long as the child can tolerate one of it. So area referrals, area dialysis, better outcome. Thank you so much. Have a nice day.
Yes, thank you so much, Dr. Syriac, for your presentation. Would like to let you know that we'll be having a session today in the evening on EMTCT. That's the last mile to elimination of mother-to-child transmission. We'll be looking at systems analysis and improvement approach. Kindly join us. We'll be glad to have you.
Yeah, thank you so much. I'll be there.